fun. And in the meantime, Robbie, hey friend,
Hello, good morning, good noon, good afternoon.
he's gonna do all the reflecting. Haha.
Yes, my favorite part, honestly. I love the idea of like having um, to iron out again something that you've already been through. And yesterday's case was absolutely fantastic. My dear friend Han presented um, a wonderful case that really took us on a journey of what connects skin disease and hematological disease. And the patient had a long-standing history of cutaneous findings and a long-standing history of hematological issues. And the connection between them is so intriguing. But we didn't start there, of course. We start in a different world. We started in the world of epistaxis, and Anne Marie shared a great approach to epistaxis or bleeding in general, with trying to understand where the lesion is. And just like Aaron, E equals MC squared, we're trying to localize both the space of the lesion and the time of the lesion. And chronic or recurrent epistaxis maps onto a chronic or recurrent bleeding problem, which may be a problem with the coagulation cascade, a problem with platelets, a problem with von Willebrand's factor, or a problem with the blood vessel wall. The good news is two of those four things we can readily measure: coagulation cascade and platelets. But hold your horses, you can't measure everything. Not everything in life is a quantitative defect. Some things are qualitative. For example, my yogurt today looks quantitatively perfect. Qualitatively, it is horrible. Why? I accidentally put some salt in it. I don't know how. I think it snuck in with all the peanut butter pretzels I put in there. Qualitatively, absolutely abysmal. Quantitatively, sufficient. Qualitative and quantitative disorders of the platelets and coagulation cascade can fool you. But if the CBC is unremarkable, we tend to move on to the coag panel on the CBC. We tend to move on to von Willebrand's issues and blood vessel issues. But yesterday, the CBC did tell us an answer. It showed us that the patient was actually pancytopenic. Yes, pancytopenic. The first step to understanding hematological issues is to localize lesion well. Is it anemia, thrombocytopenia, or leukopenia, or all together? And when you're dealing with pancytopenia, there's really one of three things that you have to track. One of three. Is there a peripheral destructive process that's accounting for the pancytopenia? Is there a bone marrow invasion going on by foreign elements like granulomas, cancers, fibrotic diseases, etc.? So again, peripheral destruction, bone marrow invasion, or impaired hematopoiesis. So when you're thinking about pancytopenia, what are you going to think of? I'm going to answer my own question. Peripheral destruction, bone marrow invasion, or impaired hematopoiesis. Now, look at that. I gave you a schema, but I really told you nothing, because you're never going to walk into a patient room and be like, oh, pancytopenia, it's either one of these three things. What's actionable? How do you make progress? You make progress by incorporating the time course. Peripheral destruction, acute. Bone marrow invasion, acute to subacute. Impaired hematopoiesis, chronic. Okay? What have we learned so far? We learned that my yogurt is salty, most important lesson of all. And then we learned that pancytopenia is one of three things: peripheral destruction, bone marrow invasion, or impaired hematopoiesis. How do you tell them apart? Watch the clock. Watch the clock. That's a reminder for me not to ramble so much, but more importantly, a reminder for you that the time course helps you filter between the three, and the only thing that causes chronic pancytopenia is impaired hematopoiesis. I fooled you again. Impaired hematopoiesis is a useless term. There's actually two features of impaired hematopoiesis. Two things live within it. One, is there a problem with the bone marrow itself, the stem cells that make the bone marrow, or is it a problem with the raw materials that nourish the stem cell? What nourishes stem cells? Things like B12, folate. What impairs the nourishment of stem cells? Toxic medications that impair within the nutrient uptake, like methotrexate, etc. Hormonal deficiencies can impair hematopoiesis, and certain toxins like alcohol. Okay, impaired hematopoiesis is either a raw material problem or a stem cell problem. Now, how do you get to a stem cell problem? That's where the skin findings of nail dystrophy and hyperpigmentation were characteristic of a very rare but important to know stem cell problem. And those skin changes can be summarized as early aging, nail dystrophy, skin hyperpigmentation. And in some cases, you can actually get oral hairy leukoplakia. And those are findings of a telomerase deficiency. And that's what the patient had. The patient had telomere deficiency called dyskeratosis congenita. It's a congenital disease of impaired telomerase healing. And so the telomeres get shorter and shorter and shorter, and your patient ages. Their skin ages quicker and their bone marrow ages quicker. But what did you really learn? You really learned that I'm not going to touch this yogurt because it's really salty. And I hope you've learned 3 things: destruction, bone marrow invasion, impaired hematopoiesis, time course, chronic impaired hematopoiesis. All right, we're watching the clock, so I'm done rambling. We'll pass the mic to Charmaine to help us.
Boom. That's all I have to say as you're talking. That was a Rezo level interjection, by the way. Oh, thanks, Robbie. As always, can always listen to you.
And Anne-Marie has a case too.
Yeah, Anne-Marie has a case, and Drew and Kurtan would love to discuss with you guys too. Woohoo! We have a whole team. Do you all want to? I know VMR community knows you all well, but tell us how you're doing. How are you doing, Kurtan?
Hey, Charmaine, I'm doing great. Glad to have you back after a long time. It's been a week almost. Yeah, it seems like a long time. 1 week without you and Rabi together. It seems a long.
That's how I feel when I'm on service and I just do the Thursday VMR, and I'm like, man, there's something missing in my life. So it's so good to have you. Drew, how's vacation going, friend?
It's going well. As I told Travis, probably going to either Siesta Key or Anna Maria Island today. Because silly me, even though I'm in Florida, I still haven't gone to the beach yet. So
I think you need to go to the beach today, my friend. And I feel like Anna Maria Island should be known as Anne Marie Island in VMR. How are you doing, Anne Marie?
I'm good. I'm excited to present a case today.
I can't wait. All of your cases are always awesome, and it's always a treat to hang out with you. Yeah, we can get started. RG, I can take the first aliquot. Perfect. Drew, do you want to rock and roll together?
of course.
Sounds great. Whenever you're ready, Anne-Marie.
Okay. The case is a 61-year-old female presenting with nausea, vomiting, and tachycardia. Would you like more HPI or would you like to discuss that?
Whatever you prefer. We can discuss this. Drew, what are your thoughts?
All right, so we're starting here with a middle-aged woman with nausea and vomiting and tachycardia, which are kind of non-specific. I would want to see if there's anything like a fever to give me a signal that there's inflammation going, but with nausea and vomiting, I think we could probably at least put in the abdomen as one of our focuses for our differential. So multiple things can cause this. If you have, say, a GI bug, like a viral gastroenteritis or a bacterial infection, you could get nausea and vomiting. If you, say, are taking a medication, or say are taking chemotherapy for malignancy, and if this, if Dr. Comfort gives us that this patient has a malignancy history, we may want to check the list of medications to see if there are any emetogenic chemotherapy drugs. COVID is always on the differential, although I do have to ask, Anne-Marie, was this case pre or during COVID times?
This was during COVID times.
Okay, so yes, COVID is on the differential. Always on the differential when we have very non-specific syndromes. It could be something autoimmune. usually we'd think of inflammatory bowel disease as like having diarrhea more than nausea and vomiting, but I'm pretty sure that Crohn's disease could present like this. In terms of endocrinopathies, hypothyroidism, adrenal insufficiency definitely could present like this. At this point, I'm honestly just kind of throwing out diagnoses and trying to see if there's any one that sticks. And I think we're going to need far more HPI and far more of the southwest corner filled in before I can actually start narrowing things down. So
Absolutely, Drew. That was fantastic. And you named some important diagnoses and systems to consider, especially abdomen when it comes to nausea and vomiting. And you're absolutely right. Nausea, vomiting, tachycardia, all quite non-specific. And I loved what you were doing in the beginning, looking for an associated symptom, right? So whenever I think about nausea and vomiting, my step one is like, okay, nausea, vomiting plus what? Tachycardia is also like tachycardia because of what? So I think like that more HPI will allow us to see if there is another what, meaning like, hey, is the patient have headache? Is this a case of like increased ICP that is led to nausea, vomiting? Does the patient has a cough? Does he have a really bad pneumonia that is causing some nausea or vomiting? Is there something going, does he have abdominal pain plus nausea, vomiting, diarrhea? Or like, you know, sometimes like people who have like really bad like acute angle glaucoma can cause nausea, vomiting. So you're absolutely right. The step one is to look for that associated symptom that presents with nausea and vomiting. And if there's no associated symptoms, then there's no localizing symptoms, then you want to like, again, always think about your no misdiagnosis, like, right? Like cardiac ACS, like obstruction in the belly of some sort, electrolyte derangement. She's 61, so we don't have to worry about pregnancy. Worth asking. And then like always running the medicine, asking about toxins as well. So I'm really excited to fill in more information so we can see where it takes us.
So the past history was about 2 months ago. She had had a partial resection of the fifth toe for osteomyelitis and necrosis in Mexico, and then had come back and had worsening of the fourth toe osteomyelitis and necrosis, had presented to the hospital about 2 weeks ago and had an amputation with a wound back in place. Had completed 5 days of antibiotics after source control, and then had been discharged to a SNF, and then was returning with nausea, vomiting, tachycardia. Well, cultures
during her hospitalization were negative, although she had received antibiotics prior to surgery. She had intermittent nausea and vomiting during the hospitalization, which was contributed to the metronidazole, but persisted after antibiotics changed and even after she completed antibiotics. Other symptoms is she feels short of breath and like it's difficult to get a full breath in. I'm gonna just pause. And then had some fatigue and dizziness. She said she had some pain at the surgical site, but really only significant pain with wound vac changes, no increased discharge or anything from the site. No abdominal pain or fevers, will sometimes feel intermittently cold, but no like shaking or rigors. Is having regular solid bowel movements without diarrhea, no blood in the bowel movements, and no dysuria. When you talk to her further, the nausea and vomiting actually started about 2 to 3 months ago without a clear precipitant. Past medical history.
Amazing. Thank you so much, Anne-Marie. Kirtan, where are you at with this?
Yeah, so interesting findings. Now, first I'm going to focus on that why the patient had her toe removed. I mean, what was the reason behind removing the toe? Is the patient diabetic? Was there any evidence of gangrene in the toe? What was the reason for removing the toe? So that's the one piece of puzzle which we will figure out along the course. And then second thing is that once it was done, the patient started to have fevers, all the systemic signs and symptoms. So I'm worried about whether there was some evidence of cellulitis. It could have been transient. It may not have been all the good cellulitis, but it could have been transient. So is there evidence of cellulitis? And was that cellulitis leading to osteomyelitis? And what about endocarditis? Are we dealing with endocarditis here? So that's the one thing, the systemic spread of bacteria and the inflammatory cytokines. Another interesting thing is that infections can sometimes cause the hypercoagulable state, right? So this patient could have developed a deep venous thrombosis that could have caused pulmonary embolism, that could be causing vomiting and tachycardia. Vomiting is a little bit rare, but tachycardia can definitely be a sign of pulmonary embolism. So it would be interesting to see what comes up in that matter. Apart from that, we are getting the fact that the patient has been having diarrhea for last 2 months. So now it is interesting to see that how we fit the diarrhea in this whole schema. I mean, the diabetes can certainly cause diarrhea because of the involvement of autonomic nervous system, but it would be rare to see the autonomic nervous system involvement so earlier or in the disease, because we still haven't got the past medical history. Is the patient yet diabetic, or she has been diagnosed recently, or she will be diagnosed in the near future? We are not sure about that. So diarrhea is a little bit hard to figure out. And then the fact that she developed the diarrhea after antibiotics, I mean, it worsened after antibiotics. So we can think about whether C. diff colitis is to blame. I mean, the patient was on metronidazole, but we know that sometimes you need oral vancomycin to treat C. difficile, and metronidazole is not enough every time. So due to all the antibiotics, hospitalization, and worsening of diarrhea, we can think about C. diff colitis also. And apart from that, let's see, what else do we have further questioning? Yeah, so I guess that's it. And of course, we can think about electrolyte disturbances like hypercalcemia, hyponatremia, which can be contributing to this. But still, there are lots of pieces of the puzzle, and probably physical examination will shed more light on that. So Rabi, can you help me now how to proceed further?
Help you? I don't know. I cannot. I have no way that I can help you. I think that was excellent. I will be honest and say I have nothing to add. But because of how I've learned one thing, and that one thing is in learners whose reasoning is very advanced, we tend to just say I have nothing to add and move on. And that is a concept called high achiever inertia, where we as educators slow down because we see somebody's doing so well and we don't help them get further. So I'm going to help you get further by asking you maybe the hardest question I've asked anybody on VMR, which is, if you, I hope this never happens, but if you are sick and you have shortness of breath, vomiting, and nausea, and you walk into an emergency room and you have these three things, what would you likely tell the provider first? That you're short of breath, that you're nauseous, or you're vomiting? Which one do you think you would tell?
Yeah, so to be honest, I will say that I'm short of breath. I mean, that's my main concern here.
Exactly, right? So why do you think this patient's chief concern is nausea and vomiting, and the shortness of breath comes out as a random review of systems? And what does that tell you, and how is that helpful? Which is the hardest question I've ever asked on VMware.
Yeah, so the fact that nausea and vomiting is the chief complaint, as the Dhruv mentioned, detours us towards the GI system more than the pulmonary system. But the fact that the nausea and vomiting could be so severe enough to cause, let's say, dehydration, then we can get tachycardia. If the dehydration is severe enough to cause electrolyte disturbances or acidosis, maybe like metabolic acidosis, normal anion gap or high anion gap, then that can cause tachypnea and dyspnea, and that will become our chief concern then. So you are right. I mean, we need to figure out that why the nausea and vomiting are so severe enough that it is causing tachycardia and all those stuff. So yeah, help me out with that, Ravi. I'm short of that. I don't know how to proceed.
Superb. You know, when there is a discrepancy between what you would, as a physician or anyone practicing in healthcare, if there's a discrepancy between what you perceive to be the chief concern and what the patient perceives to be the chief concern, there's two possibilities. The first is that that you've underappreciated the severity of the problem, and that the problem that the patient is prioritizing is much more severe and therefore deserves more attention than you think is going on. And that's exactly what you did there. The other problem is to wonder if there's a reason the patient is impaired in their ability to triage complaints. And that impairment may be on account of a chronic neurological syndrome like dementia, a chronic psychiatric disease, the effects of medications or toxins. And the truth is here, there's no signal that the patient's impaired in relaying the information to us. But it's not uncommon to patients with schizophrenia to present with complaints that you would triage lower, that actually they're trying to convey something else. So here it really stands out that the real concern is nausea and vomiting, even when there's shortness of breath. And so I agree with you. I think the focus has to be, I'm going to take the shortness of breath seriously, but I'm going to take the nausea and vomiting even more seriously because there's something that's telling the patient to really prioritize that. So in truth, keep track of that data. I think we tend to push it away and ignore it and say, oh, the patient's wrong. I'm going to pay attention to the shortness of breath because it's way more important. And that's possible. It's possible the patient has a reason to be a less than trained triager of complaints, and that's neurologic or psychiatric or toxin mediated, like patient who is intoxicated on alcohol, for example. But here, there's no reason to suspect that. So I think the nausea and vomiting is especially concerning, not just because it's occurring, but it's occurring in the face of the ignorance of shortness of breath. So we'll see where that takes us, but certainly a noteworthy thing to reflect on. All right, Emery, I'll give the mic back to you.
Okay. A few clarifying things that were asked that I forgot to mention. Due to this ongoing nausea and vomiting, she's lost about 5 kilograms in the past few months. Additionally, she just had trouble getting in full meals because of that. The past medical history included type 2 diabetes with a hemoglobin A1C that was checked last hospitalization of 8.6. However, it was controlled with just intermittent sliding scale insulin. Metformin had been stopped at the SNF due to nausea and vomiting, with like very, very minimal sliding scale insulin requirements. Also with peripheral arterial disease, hypertension, but not currently requiring any medications, and then long-standing arthritis that looked like per review was probably osteoarthritis. Medications include atorvastatin, aspirin, cilostazol, metoclopramide, sliding scale, short-acting insulin, twice daily polyethylene glycol, and as needed Zofran and Tylenol. She had previously completed cefepime and Flagyl and then was switched to ertapenem, but had not been on that for about a week and a half. Social history, she denied tobacco use, alcohol use, any sort of drug use, and all the over-the-counters were in her SNF records. And then she tends to split her time between Mexico and the US. As far as her vital signs, oh, sorry, I'll wait 1 moment. First,
There was one other medication I think that I missed.
sorry, was it cilostazol?
Oh yeah, I don't know how to spell that one. I'll add.
And then as far as her vital signs, her temperature was 36.8 degrees Celsius, which is 98.3 degrees Fahrenheit. Her heart rate on admission ranged from 116 to 140. After fluids, and she was given 2.5 liters of fluids, it was in the 1 teens range. Her SpO2 was 97% on room air. Her respiratory rate was 18, and her blood pressure was 121/65 to 145/88. I do not have orthostatics. She appeared comfortable and in no acute distress when she was seen. She had no conjunctival icterus, and her pupils were reactive. By the time she was given fluids, and she'd also previously gotten them at SNF, her mouth was clear, no dry mucus membranes or exudates. She had some acanthosis nigricans on the neck. She was tachycardic, but regular and without murmurs. She had faint crackles in her lower lung fields. Her jugular venous distension was like at about 4 or 5 centimeters above her clavicle when she was between 30 and 45 degrees upright. Her abdominal exam was completely benign. She had a soft abdomen with normal bowel sounds, no masses, no hepatosplenomegaly was felt, and no CVA tenderness or rebound or guarding. Her lower extremity, she didn't have edema, and her amputation site had a good wound bed without signs of infection. It was clean and there was no purulence or odor. She had no neurologic deficits. And I'll let y'all discuss from here.
One quick question, Amory. That second amputation, was that the entire foot that was cut, or did they just go a little bit further into the foot? Because I remember
she had a 4th toe amputation, and they got clean margins from that and good source control.
Okay. All right. So I was expecting more signal, and we have some. We now have an explanation for what may have led to the resection of her toe. She has both type 2 diabetes and peripheral artery disease. The sliding scale insulin kind of makes me cringe, since I was on endocrine consults and they really, really, really do not like just plain old sliding scale insulin. Also, I'm confused as to why she was on cefepime and Flagyl and then she was switched to ertapenem. It seems like they were basically moving her from sort of broad spectrum to, I guess, even broader spectrum and a bigger gun.
It was because the metronidazole was thought to perhaps be leading to some of her nausea and vomiting.
Oh, her nausea and vomiting. Okay, so it was basically just switching of meds to reduce side effects. Okay. And then on exam, afebrile, but that really doesn't say much. Tachycardic and staying slightly tachycardic even after 2 liters worth of fluids. BP is normal to somewhat hypertensive, but I don't exactly know what her baseline blood pressure is, and she could be technically living in like the 160s over 90s, and this would indicate that she has hypotension. And her exam kind of makes me think that, kind of is moving me away from the abdomen as our site of concern, and is moving me more closer to the cardiovascular and palm space. And even the history started moving me towards that as well, because osteomyelitis, because that bone is seeded with bacteria and it's perfused, that bacteria can go into the systemic circulation and seed the heart valves and cause endocarditis, which these symptoms are definitely consistent with an endocarditis. And then her amputation site seems like they got good source control, but again, I'm not sure if she had something seeded, and when they got source control, if she was still bacteremic, and they gave treatment to try to take care of the bacteremia, but not sure if that 5 days was enough. So at this point, CBC and CMP are obviously in the cards for this patient. I'd also want to get an EKG and echocardiogram just to see if she has anything on her heart valves and if she has any sort of electrical abnormalities as a result of it. A chest X-ray would probably be on the cards as well, given the fact that she has faint crackles in her lower lung fields, and I presume these were wet crackles, not the fine, dry ones that you would get from ILD. and also a UA as well.
Awesome job, Drew. I'm right there with you. I really, really love how you just went through the data, and I'm worried about the same thing as you are. That was really great. And yeah, as you mentioned, like the diabetes and the peripheral artery disease, not surprising, given like the osteomyelitis, and unfortunately, like speaks to how the complications of these two diseases died and like mirrored in the escalating antibiotic need, right? Like if your blood vessels are not helping the antibiotic get to the site that it needs to, I mean, the infection is deep into the bone as well. Unfortunately, it just requires for the amputation. It's hard to get source control, and it's quite devastating. So the other things to think about, like, hey, if people are getting like osteomyelitis, bad infections, what else could be happening because of these two underlying pathologies? So thinking about other manifestations of diabetes in like in the gastrointestinal tract, like gastroparesis, peripheral artery disease. If there's a correlation between the nausea, vomiting, she doesn't really endorse abdominal pain, but thinking about like the vasculature in the abdomen that can also be affected as well, although less likely in this situation. And the other thing that always like gives me pause in medication when I see is Tylenol. And if the patient is having a lot of pain, that taking around the clock Tylenol, that definitely can mask a fever. So as you mentioned, I think because of the seated infection that can go to the bloodstream, the fact that this patient is not febrile wouldn't make the pretest probability lower for me. And in the exam, as you mentioned, I think like in someone like the person who's presenting getting blood culture is making sure this is not a systemic infection and concern for endocarditis. I think that's absolutely the right move. So great job, friend. Can't wait to hear more, Anne-Marie.
Awesome. As far as her CBC, her WBC was 5 with a differential of 45% neutrophils, 32% lymphocytes, 6.9%, or I'll just say 7% monocytes, and 14% eosinophils. Her absolute eosinophil count was 0.7. Per review of last hospitalization, she had one CBC with diff on admission that showed an absolute neutrophil count of 1.1. So that was prior to admission. Her CMP showed a sodium of 138, a potassium of 3.4, a chloride of 109, a bicarb of 27, a BUN of 3, and a creatinine of 0.51. Her glucose was 101. Calcium was 8.8. Magnesium was 1.1. Albumin was 3.4. And I'll just say the rest of her hepatic function panel was completely normal. The UA had a specific gravity of 1.010 and otherwise was completely normal without abnormalities. The CRP level was 25. Did not have a comparison from last hospitalization. The SED rate was 35. Again, no comparison from last hospitalization. The COVID testing and influenza testing was negative. TSH was 1.2. Venous lactate was 2 and normalized with fluids, and trope was negative ×2. Chest x-ray showed no abnormalities aside from mild pulmonary edema. The blood cultures were obtained and pending.
Terrific. Thank you so much, Anne-Marie. Kirtan, you're up.
Yeah, so I guess we have to build up on what Dhruv and Sharmin discussed. That of course endocarditis and osteomyelitis are our chief concerns. That we are not dealing with some funky infection. That's what we have to rule out. But then the WBC count tells us something more. The eosinophilia is present. Now, of course, with eosinophilia, we classically think about that. Could it be parasitic infection? Could it be some fungal infection like coccidiomycosis? Could it be some malignancy lingering in the background? But we also have to consider the fact that given the patient had profound nausea and vomiting, what if the patient has some evidence of adrenal insufficiency? Adrenal insufficiency can cause eosinophilia. And given the fact that adrenal insufficiency is also a type of endocrinopathy, sometimes we can see clustering of the diabetes and Addison's disease, kind of like what we see in autoimmune polyendocrine syndromes. And even if we don't have full-fledged APS, we can have genetic predilection to get endocrinopathies. So that's one thing to consider. Given the fact that potassium is not elevated, the kind of what we would expect if there had been adrenal insufficiency, but the nausea and vomiting is there. So nausea and vomiting could, blunt down the rise in potassium that we would classically associate with adrenal insufficiency. So that's the one thing to consider. And furthermore, from past medical history, we now have conclusive evidence that the patient has kind of uncontrolled diabetes, right? 8.6 HbA1c is not at all desirable. And if that is the case, then we know that diabetes can hit the autonomic nerves, as we discussed in the first aliquot. And if it hits the nerves that affects the stomach, then we can get gastroparesis. If it affects the intestine, then we can get ileus. And if it can affect the colon, then we can get constipation, right? And all of those things can contribute to nausea and vomiting. And so that is very interesting way to figure it out, that whether diabetes is contributing to all of this stuff or not. Apart from that, I guess, yeah, that's it. I mean, we have to figure out whether she has infections, and then secondly, whether her diabetes is contributing to nausea and vomiting, and finally, whether we have adrenal insufficiency or something like that. So yeah, Ravi, now what we can do here?
Amazing. I'm so glad you didn't ask me to help you, because I can't. That was outstanding. And I think that the point that you're raising, and the very advanced point that you're raising, is the electrolyte abnormalities we associate with primary adrenal insufficiency are hyponatremia, hyperkalemia, and hypoglycemia. And all of those can be altered and mitigated in some way, shape, or form. You reminded us very well how the hyperkalemia can be mitigated by vomiting. When you vomit out the acid, and aldosterone kicks in, and you urinate out the potassium. And diabetes can masquerade and hide the hyponatremia and the hypoglycemia. How can the hypoglycemia be hidden? Well, if you start off with an A1C that's really high, adrenal insufficiency will bring down your glucose, but the diabetes pushes it up, and so you may end up with a near normal glucose. And the same thing with diabetes and the sodium. Hyperglycemia causes free water loss and pushes towards hyperosmolarity, and adrenal insufficiency pushes to hypoosmolarity. So you can easily see how the findings on the electrolyte panel of adrenal insufficiency can be masked by concomitant diabetes and vomiting. But the eosinophils you cannot hide. And so I'm right there with you. Let's drop our anchor on eosinophilia and see where it takes us. The most morbid condition would be a primary adrenal insufficiency, but secondary is also possible. So very, very well done. And I think you first learn what the electrolyte abnormalities are with the adrenal insufficiency, and then you learn that medicine is way more complicated and they can be hidden very easily by vomiting and diabetes. So very, very well done. Back to you, Anne-Marie.
Okay. She did get a CTA, just to score was 6 with a recent hospitalization that, other than mild pulmonary edema, did not show any abnormalities. The blood cultures were negative. It was a little complicated because 1 out of 2 came back positive, but repeat were negative and no other signs. And then otherwise, let me look at my sheet quickly. And then her review had a right upper quadrant ultrasound that, other than fatty infiltration of the liver, did not show anything previously at the sniff. At this point, a morning cortisol was checked. It was run just a little early at like 3:30 in the morning, but came back at 1.2.
Goodness, I wish that Tiago was on. Yeah, so AM cortisol of 1.2. That certainly explains the 14% EOs that this patient has in her blood. And it also would definitely explain her nausea and vomiting, her tachycardia, her blood pressure being lower than what she would be normally. And her acanthosis nigricans that may have been seen on the neck. I guess I just wanted to ask Anne-Marie, was that something that was chronic that she's always had, or is this a new finding?
It did not appear to be a new finding.
Okay. The reason why I ask is because the hyperpigmentation that can occur from primary adrenal insufficiency, so that is your adrenal glands are completely shot, can result in hyperpigmentation due to increased ACTH production. If she has adrenal efficiency, now we need to know, one, is it primary or secondary? An ACTH stim test would be able to tell us the difference between the two. And two, regardless of the cause, what's driving the adrenal insufficiency? If it's primary, is it something autoimmune? Does she have TB that hasn't been treated? Does she have meningitis that led to Waterhouse-Friderichsen syndrome in her last hospitalization, which I don't think she did? And if it's central, she'd probably need either an MRI head because there's probably an etiology that's affecting the pituitary. Otherwise, CTA, right upper quadrant, not really affecting much. The blood cultures certainly lower my suspicion for endocarditis, although that's still on the differential as well. I'd still probably want to get an echo just for completeness. The UA, she's isosthenuric / mildly hyposthenuric, which doesn't really say much. CRP and ESR of, TTE with normal ejection fraction, no valvular lesions. Goody. So, all right, endocarditis is mostly out the window. So now I think we can focus on the adrenal insufficiency. Raphael asked a good question about how low cortisol increases eosinophils. It's not necessarily that it increases the number of eosinophils, it's that increased cortisol actually causes eosinophils to apoptose. And if you don't have cortisol, your eosinophils can proliferate without that break that's there. So.
Drew, you're crushing it, my friend. That was fantastic. Really, really enjoyed discussing this case with you, and Curtin is just fantastic. You're both so great. Yeah, I'm right there with you. I think the question is like whether primary or secondary. I think if I remember correctly, like with primary, as you mentioned, the skin finding, GI symptoms tend to be like a little bit more prominent. If you were central, looking for any other sign of hypopit would be helpful. And I think at the end of the day, you want to do a cord stim to better understand. The other thing to also like consider is that, hey, if what is going on with the pituitary gland itself, is there anything going on that has led to that is leading to deficiency as well. So I'm right there with you. I'm really excited to see what Anne-Marie says.
Okay, so a Cosentropin test was performed and the cortisol was only 7.5 after the Cosentropin test. An ACTH was tested. It was not back at the time, but later came back just very, very mildly elevated, but only a little bit. And then all other FSH, LH, IGF, everything else that was tested came back within the normal range. The final etiology was figured out after discussing more with the patient. And it was through the endocrinology team that helped figure out what happened.
Kirtan, put on your endocrinology hat, my friend. Tell us what happened. Oh.
So now very little is left to figure out. That definitely it's a cause of primary adrenal insufficiency. But now what is causing it? So yeah, I mean, I will just say what I said a few minutes back, that is it APS1, autoimmune polycystic syndrome, is lingering in the background? Or, I mean, that's all I can figure it out. There is nothing else remaining.
What do you think about the ACTH level, my friend?
Yeah, I would expect ACTS to be more higher than what they are right now if it was primary adrenal insufficiency, which also makes me think that what if pituitary itself is not working as much as we would want it to work? So some kind of pituitary infiltrative disorder or some type of mass lesion in the pituitary, but then we don't have any visual symptoms that the patient has been complaining of, no evidence of any headaches, and no evidence of FSH, LH, TSH, all other hormones we would expect to go down if pituitary was the cause. So it's really hard to put in why the ACTS is not rising as much. So yeah, Harabi, now help me. I'm really lost now.
What do you think the most common cause of adrenal insufficiency in the whole world is?
Autoimmune adrenalitis, and infectious cause like tuberculosis, as the Dhruv mentioned. And given that the patient is from Mexico, I'm not sure how much prevalent paracoccidiomycosis is there, but I think even dimorphic fungi, including paracoccidiomycosis, can cause adrenal insufficiency. So it will be interesting to see how that ties in up.
Excellent. So you made a very good argument for why primary adrenal insufficiency is under consideration, because the ACTH is elevated, but it's not super high. So that's a hypothesis, but not 100%. Then there's the possibility of secondary adrenal insufficiency where the pituitary is the problem. And that's supported by the fact that the ACTH isn't as high as you would expect it to be, but mitigated by the fact that there's no concomitant pituitary abnormalities. And then finally, there's tertiary adrenal insufficiency that results from withdrawal of excess intake of steroids. And that steroid intake can be prescribed or not prescribed, intentional or unintentional. And at the end of the day, when you go back and you study the lay of the land, we've confirmed adrenal insufficiency. And the question is it primary, secondary, or tertiary? Tertiary is the most common in the world, period. That's because patients get steroids and they get taken off. So in a case where it's ambiguous, there's a case for primary because the ACTH is high. There's a case for secondary because the ACTH isn't as high as you want it to be. And there's a case for tertiary because it's the most common and would explain the ambiguous findings. So I think the key question now is, can we talk to the patient and see if there has been exogenous steroid exposure through creams, agents, pills, etc. And if that takes us to a place, that would be most informative. At the end of the day, the most common cause of the autoimmune adrenalitis typically affects people who are a little bit younger. So the age would argue against that. And secondary adrenal insufficiency from the pituitary is almost always accompanied by other pituitary abnormalities. So you add those to the base rate. And I think a detailed conversation with the patient is probably my next step. Does that make sense? Any questions about that? Okay, wonderful.
Yeah, that's perfect.
Perfect. Take us home, please.
Okay. Awesome. So the endocrine team got back to discuss more with the patient before I had gotten a chance to, and she had had a spinal injection, but it had been about 9 years ago. But they figured out that she had actually been taking an over-the-counter arthritis medication called artisomes that she had obtained in Mexico. But about 2 to 3 months ago, a provider had told her that this could be bad for her and that she should stop taking it. And so she abruptly stopped taking it. This medication contains 0.75 milligrams of betamethasone, which is equivalent to 6.25 of prednisone daily. And she had been taking it at least daily for years, 3 to 4 years prior to this. Sometimes more than once a day, and it stopped abruptly. She was started on hydrocortisone, and about 1 to 2 days later, her nausea and vomiting completely stopped, her tachycardia resolved, and she was able to eat a normal diet. It's suspected that she has a recovering HPA axis, which might explain some of why the ACTH is now mildly elevated, but probably just because of the long-term exposure, she has some adrenal atrophy. And so it does not seem that her adrenal gland has completely recovered yet, which explains it. So I thought that was very interesting. And that just like having that good history gave so much information. And I also like the case because it showed how in secondary adrenal insufficiency, you can have a normal, you normally have a normal potassium because aldosterone is not involved, but you can also have a normal sodium. You can get a low sodium because of ADH's response. But someone once told me, I haven't confirmed that this occurs early in the case. And so sometimes if you see someone later, you won't see that low sodium, which is also important for things like checkpoint inhibitor causing hypophysitis and things like
that. What a case, Anne-Marie. Man, this was fantastic. Thank you so much for presenting. I always learn so much from you. Kirtan, Drew, you both are so amazing. Thank you for volunteering. Thank you for discussing and for teaching me so much. And RG, always a pleasure, my friend. Thank you all for joining us. This was so fun. I learned a lot. Always ask the patient. Always ask the patient. Priyanka, do you want to take us home?
Yes. This was such a great case. I'm still sort of mulling over the whole journey that we took together. So we started off learning about a middle-aged woman with pretty non-specific symptoms of nausea, vomiting, and tachycardia. And I loved how, right off the bat, we named that these are non-specific and that we were looking for some associated symptom to help us localize nausea, vomiting, and tachycardia. And I think that took us at that point to the GI system, considering infectious therapy, not to forget COVID, and also other endocrinopathies and structural abnormalities like GI obstruction or ophthalmologic diseases that can lead to nausea, vomiting, and tachycardia. I really want to encourage everyone, if you haven't seen it yet, to check out the nausea and vomiting pathway that is on the CP Solver's website under the schemas that was made by a third-year med student, now fourth year, Cara Lau, which is amazing. And I think that if you don't have an isolating symptom for nausea and vomiting, then you have to consider the severity of these symptoms. In this patient, we learned that the severity was more constant, that she's been having these symptoms for 2 months. And that makes us to start to think about more chronic etiologies of nausea and vomiting. And I think even in her schema, she does allude to adrenal insufficiency. So I thought that was super awesome. When we got more data from the past medical history, the patient's medications, exam, and labs, we learned that she had a pretty severe history of things that could put her in an immunocompromised state, like osteomyelitis and diabetes. And we started to think about some of how these illnesses could relate to her presenting symptoms, including nausea, vomiting, but also she presented with shortness of breath and crackles on exam. And so we started to localize those symptoms to something maybe like endocarditis, lung disease, and layer on the past medical history of diabetes to explain her presenting symptoms. At this point, I think we were still sort of pursuing several paths, but I would say the real pivot point in this case came from the labs in which this patient had eosinophilia, which helped us to consider different causes of eosinophilia in a patient like this, including fungal causes, parasitic causes, malignancy, and also adrenal insufficiency. I think it was such a good point that was discussed by Kirtan and Robbie that adrenal diabetes can mask a lot of the presenting symptoms of adrenal insufficiency, including the hypoglycemia, hyponatremia, hyperkalemia. And I think it is so important to keep in mind that in a diabetic patient, the light abnormalities simply cannot rule out adrenal insufficiency. Then after we got more data about the AM cortisol and the Cosentropin test, I think that really put us in the bucket of this patient has adrenal insufficiency, and that diagnosis explains her presenting symptoms. However, then the question became, what caused her adrenal insufficiency? And we wrapped up with an amazing discussion about the different causes, such as primary, secondary, and tertiary. And again, I encourage you all to look at the illness script for adrenal insufficiency on the CP Solvers website. But I think what stood out to me most from this discussion was to really consider the base rate of disease. For me personally, it's so easy to kind of get into the theoretical, like, okay, what's causing all these things? But the base rate of disease tells us that most commonly patients have tertiary adrenal insufficiency because so many patients are prescribed steroids out in the world. And so abrupt withdrawal can precipitate adrenal insufficiency and present with these really nonspecific symptoms. So all in all, I think it was such a brilliant discussion of adrenal insufficiency and how to diagnose it. But most importantly, to ask the patient important questions in their past medical history to help us figure out what's going on. Thank you so much, Anne-Marie. This is an awesome case.
Priyanka, that was fantastic, my friend. Thank you, thank you, thank you. Have a wonderful day, you all. Bye.
Hi, guys.
Hi, everybody.
Bye, all. Thank you.